Okay, so this is a normal looking shoulder, and the way to look at it normal is. Okay, so this is. Okay, so okay, so Dr. Umair, your microphone is not connected, therefore you can't hear us. Okay, but yeah, anyway. So basically, we want to start on shoulders instability and cuff tears. So you can see that this shoulder is intact, okay? But at some stage, it has dislocated, and you can see that from big, huge translucency in that, and that's a Hill-Sachs lesion. Can everybody appreciate that, yeah? Can you see that translucency?
Yes, sir.
Okay, so that means something has happened, and in the past, this is what happened. The shoulder dislocated and got stuck, okay? So when a shoulder dislocates and reduces, how would you know that which shoulder is the one that's going to cause dislocation in the future or will have a recurrence? Do you have an idea?
Sir, it depends upon how if the patient is young and he is having the traumatic dislocation, and he is likely to have a dislocation in the future.
Okay, so the easiest thing is age, okay, and various other complicated, you know. So 100 minus age is the incidence of recurrence. So if you're 15 years old, your chance of having a dislocation again is 85%. Okay?
Yes, okay, sir. Yeah, yeah.
Okay, and so if you are 50 years old, then the chance of having a recurrent dislocation is 50%. So the older you are, the more difficult it is, okay? So
okay, sir.
That's the easiest way to understand, okay? Do you know what I'm trying to show you in this picture then?
Yes, sir, Beaton's criteria.
Okay, so what is that?
Sir, this is basically Beaton's criteria for generalized hyperlaxity. It has 9 scoring system. The figure A is the score 1, then 2 each for the other 4.
Okay, so double, yeah, and finally, if you can bend and touch the floor without bending your knee, it becomes 9. So there is a range between 1 to 9, okay? So it is important to understand that, and the reason to understand that, is that after age, the second most commonest cause of recurrence is multidirectional instability, or instability because of laxity, okay? So if you have a trauma and you dislocate and you're very young, you will recur. If you don't have trauma, you dislocate, but you are multiple jointed, then you will have a high chance of recurrence, okay? And to assess whether somebody's got multiple joint or not, if you are young and you come with a dislocation, even for the first time, you must assess them to make sure that they have no multidirectional instability, okay?
Okay, sir, okay.
Okay, so this is called the Stanmore's triangle. Okay, you must understand this. The Stanmore's triangle causes about type 1, type 2, and type 3. Okay, in type 1, it's mostly traumatic. Okay, in type 2, they are atraumatic, and type 3 are idiopathic or one with muscle patterning. So the type 2 are the multidirectional or the soft tissue with multiple joint laxity. The type 1 are traumatic. And type 3 are people who either dislocate their shoulder themselves or they have abnormal scapular setting or muscle patterning. There's a combination of all. You know, you can have a person who is multiple directed instability but had a trauma and dislocate, okay? Or you can have somebody who is multiple directional but now wants to dislocate his shoulder every time to get attention from the doctors or from his family. So you can have a combination of all these 3, but predominantly they are called the traumatic one, the atraumatic one, and the muscle patterning, or the one who have got idiopathic causes, okay? So the next thing is Tubbs and Emery. This is a term that is used a lot. Does anybody know what Tubbs and Emery mean?
Yes, sir. Sir, Tubbs is actually traumatic unilateral instability dislocation which with Bankart lesion which requires surgery, and usually it is the most common and traumatic anterior shoulder dislocation.
Okay, so you have Tubbs, which is what you just said, and you have Embry, which means the multidirectional or atraumatic multidirectional. They are always bilateral. They need rehabilitation a lot more, and occasionally you can do an inferior slide for those. Okay, and again, I said there is a combination of both, or there is some patients that have a combination of both. You must be careful with those ones, because if you don't give a multidirectional person who has hurt and torn his ligament surgery, he will keep dislocating, although he may have a lot of physio. Okay, so this is the diagram that I draw. So you have a Stanmeyer's triangle, and this is what I draw. Yeah, so you have trauma, you have laxity, and you have idiopathic patients. Okay, this is the worst group to have. You know, this group, which is a combination of trauma with multidirectional and do want to dislocate their shoulders themselves. This is the most difficult group to have. Most of the patients fall into this group. Okay, the second commonest is laxity. This is rare. Idiopathic people who try to dislocate themselves, but if you have people who are trying to gain attention and have trauma of some sort and were lax to begin with, this is a nightmare to sort out. Okay, so you must understand that if you have a dislocation, you need to know whether it's traumatic or multidirectional. You need to know how young or old they are, and then you need to know, is there an element of idiopathic or people who want to dislocate their shoulders again. Once you've done all that, then what is the next investigation you want to do?
Sir, next, after detailed history and clinical examination, we will go for radiographs.
Your X-ray will already be there because they have been admitted from A&E, or somebody's asked you to come and see them, isn't it? So the plain film X-rays, AP and lateral will be always there, which is good. What else do you want to do now? What X-rays do you want to do, or investigations you want to do from here onwards after you've done your clinical examination history taking?
Sir, I would like to have an auxiliary view if the patient is not very painful, or you may have a Valpeau view, or you may have a scapular Y view. All three can be taken.
So all these this is dislocated, okay? But we want to plan further. Now we know it's dislocated. So what are the two common tests you can do, and tell me what information you can get from?
Apprehension test.
No, clinical, not clinical. Now we're talking about investigation. You don't want to dislocate somebody who's already dislocated, isn't it? So when you take history, your Beaton's criteria and your apprehension, all that has been done in it. So now the patient is ready to have something done in life. So what investigations can you do now?
Sir, MRI.
Okay, so a plain MRI will give you very little information. So you want to do either. Yeah, you want to do a CT scan, which will tell you if there's a Hill-Sachs lesion or not, if the glenoid is worn out or not, or you do an NMR arthrogram, which will give you volume plus Hill-Sachs plus what the glenoid looks like. Okay, and why do we want to do these two investigations? What is the reason for doing these two investigations?
Sir, to exactly know about the defects in the glenoid and the
do you understand what a bipolar lesion is?
Yes, sir. When lesion is on the both sides, it's Hill-Sachs and the Bankart, both are there.
Okay, so your outcome for these patients is one of the three. Yeah, you can either do physiotherapy and rehab them, or you can do a Bankart repair, or you can do a Latarjet repair. Okay, so you need to do these investigations to find out what you want to do for these patients. For a Bankart repair, the patient should have a Hill-Sachs lesion of less than 25%, should have no bipolar lesion, no on-track, off-track lesion, and a straightforward just labral detachment. If you see it's a bipolar lesion and the patient has got an off-track lesion, then you want to do what is called a Latarjet procedure. Do you understand that? I will explain this to you in a minute. But the reason you want to do a CT or an MR arthrogram is to understand if the lesion is unipolar or bipolar, so that you can plan surgery. Okay?
Oh, okay, sir. Okay.
So a bipolar lesion is when there is a glenoid bone loss, there is humeral bone loss, and they end up in engaging. Okay, so when the defect engages in the glenoid, that is called an engaging lesion. This is the old classification. The modern classification is on-track, off-track lesion. I'll show you how it is. Okay, but it is not a simple lesion anymore. Now it is a bipolar lesion, which means both the humeral end and the glenoid is involved. And if you try to do soft tissue procedures, this will not be stable, and they will dislocate again and again. So you need to do something more than doing a basic stable soft tissue lesion. And for that, you extend the glenoid. Okay, you take the coracoid and stick it in the glenoid, which is a Latarjet, so it no longer engages into it. Okay, the engagement is not there anymore. So what we do now is called an on-track and off-track lesion. Okay, do you understand what an on-track, off-track lesion is?
Not exactly, sir.
Okay, so when you put your hand in abduction and external rotation, okay, that's the most vulnerable part when it's going to engage. So the glenoid and the humeral head should have 84% contact. This is what an MR or a CT scan will tell you. Okay, so the glenoid,
Okay.
the humerus, on this picture, this is the glenoid tracking, and this is the humeral head. So the humeral head will move on the glenoid and it will track on it like a rail track. Okay, if you have a defect, you know, if the defect comes in the path, then it either engages or it's called an off-track lesion. Okay, if the defect, which is either on the humeral side or on the glenoid side, does not come in this track, then it is called a non-engaging or an on-track lesion. So if you look at this picture, the defect is less than 83%, therefore it is not engaging, therefore it's an on-track lesion. Can you understand that? This is your glenoid, and this is the humeral head. In abduction and external rotation, it is not engaging, which means the defect is smaller than the glenoid cavity. Therefore, it does not engage. However, in this particular lesion, you can see that the lesion is bigger than the glenoid cavity, and therefore it engages. Understand that? With the two.
Yes, sir.
Yeah, easy. So you must understand that in the glenoid tracks, or the glenoid acts as a track for the humeral head to roll onto it. Okay. If at any stage the humeral head engages into the glenoid, or the track is less than 83% of what the glenoid shape is, it will engage, and therefore it will be called an off-track lesion. If it doesn't engage, it will be called a non-engaging lesion or an on-track lesion. So for an on-track lesion, you can do a soft tissue procedure, but if you have got an engaging lesion, then you have to do a Latarjet procedure. That is why it is important to know whether it's a bipolar or not.
Okay, sir.
So that will give you in which patient you can do a Bankart repair and in which patient you can do a Latarjet procedure. Is that easy?
Yes, sir.
Okay. Okay. So if you look at it, this is the same picture explained. The glenoid is more than 83% available for the humeral head to track into, and you can see that the tracking, can you see that? Tracking is bigger than the lesion, and therefore it will not engage. Okay?
Okay.
And it's the same picture again. I just want you to understand the concept. In here, this is called an on-track lesion because you have a Hill-Sachs lesion, but the glenoid is big enough for the head to be on it rather than off it.
Okay.
Okay, and if you look at this, the lesion on the humeral side is far bigger, and there's a glenoid missing, so it becomes an off-track lesion then, which means that it's going to engage. It's going to lock into that defect. So on-track and off-track. Remember this, on-track and off-track. This is a new concept, and I think most examiners, or the question will come on which one you want to do a Latarjet or not, like, okay? So this is a...
Okay, so
sorry?
Off-track is engaging, right? Off-track is engaging.
On-track is non-engaging. Off-track is engaging.
Okay.
Yeah.
Okay, sir. Okay.
It's on the track, so it's not engaging. And off-track is off the track, so therefore it's engaging.
Okay, sir.
So this is an important slide again to remember. This is the treatment management for people with bipolar bone loss, which has got a Hill-Sachs defect and glenoid is missing. Okay, and they are described into 4 groups. Group 1, when the glenoid defect is less than 25% and it's an on-track, then you can do an arthroscopic or an open Bankart repair. Okay, so if it's an on-track lesion and the glenoid defect is less than 25%, which is normally the case, otherwise it would be not on-track, then you can do an arthroscopic repair. If you have a glenoid defect less than 25%, but it is an off-track lesion, i.e. it is falling off, which means there is some element of the glenoid also being broken, then you would do what is called a arthroscopic Bankart repair plus a remplissage. You understand what a remplissage is?
Remplissage, yes, sir. It is the capsule and the lesser tuberosity are sutured into the defect.
So you cannot open. You cannot do this open. It can only be done arthroscopic. It is putting the infraspinatus and the capsule into the defect. Okay, and when you do that, it acts like a pulley and won't allow it to fall off. So you have done a repair in the front by reattaching the Bankart, and you pull put the infraspinatus and capsule at the back of the defect to stop it from falling off. Okay, you will always put your sutures for the Bankart first, and then do the remplissage, then tighten the remplissage, and then tie the Bankart. Otherwise, if you tie them in the front, it won't go back. But this is a big, huge mystery. A lot of people don't do remplissage, so I don't do remplissage. The reason for that is I can never get it right. So I will do a soft tissue repair in this group 1. Everything else, I'll do a Bankart. I will do a Latarjet. Okay. So, but you can, in the exam, if an MCQ or a question comes in, that what is the indication of remplissage? And the indication of remplissage is that if you have a less than 25% glenoid defect, but you're off track, then you do a front and back repair. The back repair is done after the front sutures are put in. Then you tighten the back, and then you tighten the front. If you tighten the front, it'll go to the front. It won't be able to go back again. You won't have stability. So you have to put the infraspinatus and the capsule at the back into the lesser tuberosity, or where the defect is. It is not the lesser tuberosity, but it's actually where the hillside defect is. That's where you put all these things into, yeah? To stop it from falling off, that's what you're doing, yeah? And in group 3, when the glenoid defect is more than 25%, and it's an on track or an off track, you will do a Latarjet. So if you've got more than 25% of glenoid missing, you'll have to do a Latarjet. Okay?
Okay, sir.
So
okay, sir.
There are 2 types of Latarjet that people are doing. So there's a congruent Latarjet and a non-congruent Latarjet. Okay?
Okay, sir.
This is the first described by Latarjet, and it was popularized by Julie Walsh from France, right? He is in Lyon, where the Latarjet started his work. I've met this guy, and he's a very nice guy. So what they did was, this is the undersurface of the coracoid. They used to cut it, and they used to take the undersurface and stick it in the defect, okay? And then they used to use the coracoacromial ligament and augment the labrum, okay? When you do this process, it is called non-congruent, for the reason is there is non-congruency. Can you see that? But a lot of people do that. That's the easy one to do. So in the late 90s, Burkhardt and De Beer from South Africa, they talked about a congruent Latarjet. And what they do is they cut the coracoid, and the undersurface is put parallel to the glenoid, because the undersurface curve matches the curve of the glenoid. So when you repair these, it becomes congruent, because the whole thing becomes soft, okay? Here, you cannot do a coracoacromial ligament attachment. So this is called a triple secure procedure, and this is called a double secure Latarjet, because in this, you have a bony extension, you have the muscles of the conjoined tendon supporting you when you're in abduction external rotation, and you also have the coracoacromial ligament augmenting the labrum. Whereas in this, you have no augmentation in the labrum, but you still have the arch supporting your glenoid, and you also have the conjoined tendon helping you. Okay, so this is very easy to understand. Is where you put your undersurface of the coracoid. It becomes congruent and non-congruent, yeah? And this is what it looks like in an X-ray, yeah? You can understand that. This is what it normally looks like. So you don't need to go into it, but if you look at it, this is the conjoined tendon. Can you see this? That's the coracoid, and this is the conjoined tendon. You take this off, and you stick it to the coracoid. I do congruent Latarjets. So, and when you do this, you can see this is the conjoined tendon. Can you see that? Yeah. This is the coracobrachialis and the biceps tendon attached to the coracoid. And this is the subscap margin. So when you go in abduction and external rotation, this acts as a hammock, and it stops the head from dislocating.
Right.
Okay, so we are done now with instability. Now ask me questions. You need to have a clear concept of this. So before we move on to cuff.
Sir, what about Bristow, the older one?
Nobody does that anymore. Okay, so Latarjet described the procedure first. Rory Bristow was a colonel in the British Army, and in the Second World War he started doing for his patients. But what he did was he used to take the glenoid, the coracoid, and detach the conjoined tendon and put one screw here. Okay, so you did not have the stability of going up in abduction and external rotation, because there was no conjoined tendon to give you the hammock or the sling effect. So Rory Bristow described a procedure where the coracoid or the fibular graft was stuck into it with one screw, but there was no soft tissue attachment. So therefore, it was stable in one plane but not stable in multiple planes. So if you were an athlete or you were a baseball pitcher or you're a cricket bowler and you didn't have the lateral with the conjoined tendon, the Rory Bristow, you won't be able to bowl again because the shoulder will dislocate in abduction and external rotation. The key difference is the conjoined tendon. In the Rory Bristow, there is no conjoined tendon.
Okay, sir.
Any more questions?
Sir, for Ambri, the multi-directional instability, first we do physiotherapy for 3 to 6 months and then we go for the rotator interval closure and capsule plication. This is the all treatment that is required for that.
So what you will do is you will ask the physios to do what is called scapular setting exercises, which is physiotherapy. Yeah? So the scapular setting exercises means that the glenoid with the scapula follows the humerus. It does not stay where it should, but it follows the humerus. So therefore, it gives it little opportunity to dislocate. These are people with high volume. And do you understand why they dislocate? Do you know why they dislocate?
No, sir.
Okay. So can you imagine that the shoulder is a plate and a ball? So the plate is the glenoid and ball is the humeral head. So on both sides, you have capsules and labrum, and they're not strong enough to hold the shoulder from dislocation. However, if you remember your geometry, on a straight line, if you have a circle, the circle needs to be half off before it can fall off. Do you remember your geometry? So for a shoulder to dislocate, half of the shoulder, humeral head, should be off the glenoid before it can dislocate. However, the capsule labral attachment, and the labrum acts as a proprioceptive mechanism. So when the shoulder comes near to the capsule or to the labral capsule, the structures, a mass effect takes place and it allows to contract all the shoulder muscles, so therefore the shoulder does not dislocate. In people who have high volumes or people who have got multidirectional instability, there is no capsule to stop to start the proprioceptive mechanism, so the shoulder falls off. There is nothing to stop it purely because there is no proprioceptive response. So therefore, you are training the person with the help of the physios to not allow the ball to fall off the socket. So the humeral head stays in the glenoid. And therefore, it's called scapular setting exercises to allow the glenoid to follow the humeral head so that it does not give it a chance to fall off. Is that clear?
Yes, sir.
You're not clear. You're just saying yes, sir. Yeah. So,
no, sir, I'm clear.
Imagine this, okay? The circle is the humeral head and the plate is the glenoid, okay? So the humeral head, the circle, will fall off the plate if half of it is off it, okay? There is nothing to stop it from falling off if half the circle is beyond the glenoid, okay? So for the nature to stop you from falling off, you have a proprioceptive response. So the capsule and the labrum are not strong enough to stop you from falling off, but when you go near it and you touch it, a proprioceptive response comes and it stops or it tightens all the muscles all around you to stop you from falling off. Okay? So the proprioception or the physio teaches the glenoid and the scapula to match each other so it does not fall off. When you're doing surgery, you are tightening the capsule, okay? And tightening the capsule causes the proprioceptive response to come quicker. Therefore, the shoulder does not fall. The capsule itself is not strong enough to hold it from falling off. Okay, that's the misconception. Everybody thinks that the capsule stops it. It's not. If the proprioceptive response stops it. Okay?
Right, sir.
Okay, it's not difficult. You just need to understand. It's just conceptual rather than remembering all these things. You must understand, you know. I mean, otherwise, I mean, I like shoulders because it's fun. You know, it is a lot of fun. Okay, so are we happy on cuff, on glenoids and labrum and instability? Should we go to cuff?
Sir, there was also one concept you were talking about, that how to differentiate between ligamentous laxity and the issue with the rotator interval. That is that the circle sign it disappears on external rotation. Can you repeat that concept?
So I did not say anything like that. What I said was the difference between multidirectional and traumatic is history first. There will be no history of trauma, or sometimes confusing history of trauma. That's the first. The second thing you will do is called a Beaton's criteria, which will tell you whether the patient is lax or not. Okay, once you've done that on clinical examination, the differentiation between traumatic and atraumatic is the sulcus sign. So in a normal person, who multiple directed and has got no instability, if you do a sulcus sign, you will get it present. But if you externally rotate while you're doing the sulcus sign, it will disappear. That means the person does not have multidirectional instability. Okay.
Right, sir.
But these are a lot of things you have to do together. You can't do one on its own to say this is what's happening. Like, okay, a lot of things have to be done together. So you need to take history, proper examination. You need to do all the tests for instability. You need to do all the tests for laxity. You need to do the Beaton's index. Then you need to assess the person on its own generally, whether he's mad, he's not mad, he's doing it purposely. Has he got element of tubs or ambry? All these things together. Then you do a CT scan or an MRI scan to tell you how much the volume is and if you've got a bipolar or not. And then you decide whether you want to do physiotherapy, you want to do a Bankart repair, or do a Latarjet procedure. It's a combination of everything to come up to the decision of what to do with the person.
Can traumatic be multidirectional?
Yes. I think I showed you a picture. I showed you a picture. In a minute, I'll show it to you again. Okay. So if you look at it, this is called the Stanmore's triad. Okay. So if you are multiple directional by birth, here, and you fall, so you can have a traumatic element to it. So this bit, where it's overlapping the lax patient with a traumatic element, like this bit here, that's a person who was lax but has now trauma. So these are the people that we miss. In the sense is we know they have a Beaton's index, right? And so we get the physios to work with them, but they're not stable. And then we realize that it's not just a laxity, but they also have a traumatic element into them. So although you proprioceptively train them, they don't be stable because the capsule is miles away from where it should be, even when you make the glenoid move with the humeral head. So therefore, these are a combination of lax people who had an injury. The worst combination, I call them idiots, not idiopathics, but idiots who want to take attention and try to dislocate their shoulders. If they have fall, or if they were lax to begin with, they are idiots and they fall. That little group of patients, although very rare, is the most difficult people to treat and manage. Even the traumatic one who are idiots, or the lax one who are idiots, are difficult to manage. But the ones who are lax are trying to dislocate their shoulders themselves and have an element of trauma. They're a nightmare to sort out. Okay, so go back to cough now, yeah? Go on, listen. Go on, ask. See, I can't see you guys today. For some reason, my computer is not allowing me to see anybody, so I don't know who's joining me. Normally, I can see people on the side, but for some reason, my computer is not allowing me to do that today. Okay, so are we okay? Should we move on? Yes, no?
Yes, sir. Yes, sir, yes.
Okay. So describe this X-ray. Just very quickly so that I can tell you where you can go from here. What do you see on this X-ray? This is a 67-year-old person who's come to the clinic and he's got a painful shoulder and he cannot do anything, and you've done an X-ray. Unfortunately, I don't have a lateral view, but that's the only X-ray you have. What do you see on this X-ray? Nobody wants to go.
Yes, sir. This X-ray shows that AP projection of the left shoulder and the lateral one-third clavicle fracture.
There's no fracture. So this is a skeletally mature shoulder of the left person. It's showing a high riding humerus. The humerus is not in the socket. Can you see that? Yeah.
Yes.
And the humeral head, it's got no tuberosity. It's called an auto decompression. The tuberosity is gone, right? And it is saucerizing the acromion, i.e., it is knocking the acromion. So it's got three features telling you that this person doesn't have a cuff. Okay, so the acromion is holding the humeral down because the acromial arch is supposed to hold it, and if you have no arch, then it will go and touch the acromion. And there's no tuberosity because when the shoulder moves or the humeral head moves, the acromion is smoothing off the tuberosity. This is called auto decompression. Okay, and obviously the socket and the humeral head is not matching each other. The line that you draw from the neck of the glenoid to the humeral head, like the Shenton line of the hip, is broken. Can you see that, all of you? No.
Yes, sir.
Oh, no, that is not convincing your yes, sir, you know. So So this humeral head is not facing the glenoid properly. Can you see that? Yeah. So there is if you draw a line. Okay, let's go back to the let's go back to the pictures of that. Yeah. So if you look at this line, although there is arthritis, this line is intact. Can you see that? Yeah. There is arthritis, but the line is intact. Yeah.
Yes, sir.
Okay, so now if you go back to the top again, well, not this way, the other way. Okay, so if you go down here, you can see that line is not intact anymore. Can you see that? Yeah.
Yes, sir. Humerus is migrated.
Yes, this is called a high riding humerus. Okay, the technical word for this is a high riding humerus. So the second thing you see, although this is not dislocation, it's like a bulb. Okay. So the reason for that is that the tuberosity here is touching the acromion every time because there is no supraspinatus to depress it. So it is smoothing it off. This is called auto-decompression. So it has decompressed its tuberosity, and therefore it becomes a soft shoulder. And then it's saucerizing the acromion, i.e. touches the acromion, so it is impinging on the acromion also. These three signs will tell you that there is no cuff. Okay? So if you see an X-ray with a person who has got potential that the cuff is gone, after you've taken a proper history and examination, what test would you do? What are the special tests for cuffs? Nobody wants to talk. Yes, no? So how do you assess clinically for supraspinatus tendon, infraspinatus tendon, subscapularis, and teres minor?
Abduction with internal rotation.
Okay, so for assessing the supraspinatus tendon, what you do is you ask them to extend their shoulders and abduct to 15 degrees, which is the arc of the glenoid, yeah? And then ask them to point a thumb downwards. In this direction, the supraspinatus tendon is directly parallel to the forces. Okay, then you ask them to abduct against resistance and you look at the back to see the supraspinatus. This will be weak in a tear, or it'll be non-functioning if there is no function of the supraspinatus tendon altogether. That's how you assess supraspinatus. Then infraspinatus and teres minor both cause external rotation, but both help to do external rotations. So you ask them to abduct the shoulder and externally rotate. And if they can't externally rotate or are weak against resistance, then either the infraspinatus or the teres minor is not working. Okay, so for teres minor, you do what is called a Hornblower's sign. That is internal rotation in abduction. They are not able to do internal rotation in abduction. So it's called the Hornblower's sign. And if you can do what is called abduction and external rotation, that's the infraspinatus lag sign. So if they don't do external rotation, you ask them to do teres. I mean, I can't show you pictures, unfortunately. Otherwise, I would have. Let's see if I can start. Okay, video. Okay. Can you see me now?
Yes.
Okay. So ask them to extend like that and point the thumb to the floor. Yeah, in the 15 degrees from the shoulder, and resistance against that is supraspinatus. If it's weak, the supraspinatus is not working, or you can't do this movement at all. Okay, then you ask them to do external rotation against resistance. If the external rotation is okay, then infraspinatus and teres minor is working. If the infraspinatus and teres minor, one of them is not working, you won't be able to have external rotation full. So then you want to know whether it's the infraspinatus or teres minor. So this is called the Hornblower's sign. So abduction in internal rotation, if you can do this, teres minor is working. If the teres minor is not working, you have a position like that. This is called the Hornblower's sign. Okay? So you can't do this if the teres minor is working. So you ask them to abduct and internally rotate. And you abduct and externally rotate. And if you can't hold that, then the infraspinatus is not working. This is called extension rotation lag sign. Okay? So one is abduction and internal rotation. One is abduction and external rotation to differentiate between infraspinatus and teres minor. Okay? And the other one is for the subscap, you press the belly sign and bring your elbows forward, and you ask them to keep the elbows forward and push in. If they can't keep the elbow forward like that and they fall like that when they're pushing in, then the subscap is gone. Okay, so that's the easiest way of assessing your cough. So you supraspinatus stress test, then external rotation, and if external rotation is weak, then you do a Hornblows, which is internal rotation in abduction, or external rotation abduction is infraspinatus, and the belly press is the subscap. Easy?
Yes, sir. Got it.
You got it now, okay. So in this particular case, the patient has got no cough. So we now clinically examined him, and clinically his supraspinatus is weak, okay? So what next?
We would assess it on radiological and further investigations to see what is it micro tear or massive tear.
Okay.
Plus,
so there is a thing called khaya piya kuch nahi, glass thoda 10 rupees. Okay? So you've said a lot of things, it doesn't mean anything. So in the exam, you have to be very specific. So you will say, now I will proceed to do an ultrasound of this patient. Okay? So depending on how good your investigation or your department is, you can do an ultrasound, or you can do it yourself, or you can have an MR. Here, you don't need to have an MRI ultrasound, you need a plain MRI scan. Okay? So I do my own ultrasounds in my clinic. Okay, so the guy, I have a portable ultrasound like this, and it works on my telephone. So I will do a cuff, and then I will decide after I've done an ultrasound what kind of tear it is or where it is. It is called the Habermeyer classification, and you need to know if your supraspinatus is gone, okay, or your infraspinatus and teres minor is gone, or your subscap is gone, depending on where your ultrasound will pick it up for you. Very easy to do that on ultrasound, okay. If you don't have ultrasound, then you can ask your MRI scan guy to show you an ultrasound, and that MRI scan will tell you where the tear is and how retracted it is. Just give me a second, okay? Yeah, hello? Okay, okay. Okay, so you do an ultrasound or an MRI scan to tell you where the tear is, and you need to anatomically localize the tear, and you need to know how retracted it is. And after that, you do a classification, which will tell you that your tear is less than 1 centimeter, more than 3 centimeters, between 3 and 5 centimeters, and more than 5 centimeters. So why do you want to classify the tear size? Do you know?
the management depends on.
So how?
Conservative or surgically repair.
So you cannot do conservative management of cuff tear unless you're a very small tear, and even then physiotherapy may or may not work. So the reason we manage or classify the tear is if you have a massive tear above 5 centimeters, even if you repair it, the re-tear rate is very high and they have a high complication rate. So you cannot repair a massive tear. But these repairs, other ones you can do, okay? So the reason you classify them is it big enough to not be able to repair, or even if you repair it, long-term outcome is poor. So there is evidence to suggest that anything bigger than 5 centimeters, even if you repair it, their long-term outcome is very poor. That's why you want to classify them where they are and what size they are, okay? So the next thing is you do is what is called the Hamada staging, okay? And in the Hamada staging, you have 5 or 6 stages. The first stage is a high riding humerus, and this is more than 6 millimeters distance, okay, which means that the cuff is not fully torn, it's still there. You can do something with it and repair it. If it is less than 3 centimeters, then you have to do something with it. If it's touching the acromion like we show in the pictures and the x-ray I showed you, you definitely have to do something. However, if you start with arthritis, then there's not a lot of cuff repairs you can do, because the glenoid and the humeral head is not normal. So it is like anything else in life. You can't do soft tissue surgery if you have arthritis in the joint. Are we clear on that? Yeah, so even if you have a cuff tear, but a joint is not normal, you can't repair the cuff because you've got other problems. Okay, and you also do an MRI scan, which is the Gottlieb classification, which will tell you how good your supraspinatus is in bulk and how much fatty infiltration it is. So if you have this, you can repair them. If you have something like this, you can repair them. But if your supraspinatus is getting so small that it's going into the notch and it's hardly visible in an MRI scan, your repair is not going to help. Okay, so now we know that if you have got a classification where you've got bigger than 5 centimeters tear, you cannot repair it. Or if you have got a arthritic shoulder, you don't need to repair it. Or if the quality is not very good, you don't need to repair. Everything else you can repair. Are we clear on that?
Yes.
So we understand now that we need to know the size of the tear to decide whether repairing it is or not repairing it is good. We need to understand that the tear, with the tear, there is no arthritis in the joint, and we also need to understand there's no fat infiltration. The bulk is normal before we apply tears to repair it. Everything else, we'll have different sort of management for them. If you're above 65 to 70, you can have a reverse shoulder, or if you have less than 70, but you've got no arthritis, then you can do what is called a superior capsular reconstruction, or you can do a graft or something like that. But for repair a cuff, you have to have normal shoulder, you have to have good quality cuff, and you have to have less than 5 centimeter tear. Okay, and the whole idea is to put the ball back in the socket, because tell me what the supraspinatus does for, what is the job of the supraspinatus in the body?
Sir, abduction of
what, sorry?
Abduction of shoulder for the first 15 degree.
So you are telling me that Allah Ta'ala created a muscle that job in life is only the first 15 degrees of moving the shoulder.
It keeps the head within the socket.
That's absolutely right. How are you, Sama?
I am fine, sir. Assalamu alaikum.
Great to hear from you. So remember,
Thank you.
no, there are a lot of tests done where they have inserted probes and done nerve conduction and EMG studies of the supraspinatus tendon. Every time the shoulder moves, the supraspinatus is active. Okay, so which means that the job of the supraspinatus is to put the ball into the socket. So if the ball is in the socket, it's congruent, then all the other muscles can make it work. Okay, if the ball is not in the socket, it's not congruent, and you'll have no function or very little function. Okay. Okay.
Yes.
So final bit of the cuff, and then we can call it a day. Yeah. So when the cuff goes away, you can see the humerus goes up, and you can repair it. And you can only repair it if there is no arthritis, the tear is less than 5 centimeters, and there is no fatty infiltration, and the quality of muscle is good. Okay. So you will repair these. So if you look at this, this is called a toe repair, which is called a transosseous equivalent or a double row repair. And the reason we call this a toe repair or a double row repair is in the past, when we were doing open surgeries, we used to make holes into the humeral head, and we used to pass the cuff sutures through the hole to allow it to come and touch the bone, because that's the only way it will heal. So now what we do is we call it transosseous equivalent or toe repairs. We can't do it transosseous because we don't put it through the bone, but it's an equivalent repair, and it's a double row repair like anything else in a tendon. So if you repair the tendons in the finger, you have a core suture and you have a running suture. Agreed? Hello? Nobody wants to say anything. So you have a core suture and you have a running suture. So there's your core suture, which is a mattress suture, and this is the running suture, just smoothing it. This is called a double row repair. Yeah. Now, if the supraspinatus is not working, and you have arthritis, and the person is about 70 years old, then you do what is called a reverse shoulder. Okay, it is the same principle. Mechanically, the reverse shoulder is putting the ball back into the socket, right? Which means it makes it congruent, and the deltoid can then do flexion, abduction, and extension. Okay, so the key is to put the ball back into the socket. There are tricks now that if you're not old and you're not arthritic, but you're irreparable cuff, you can do what is called a balloon procedure, where they put a balloon in the shoulder, and the balloon mechanically puts the ball back into the socket, and therefore you have the deltoid working. But this is the whole shebang of doing what you can do in a cuff deficient shoulder. Depending on age, how big the tear is, and depending on how the patient is, you can offer them repair. But if they're old, replacement or an interposition arthroplasty. Okay. So this is what a superior capsular reconstruction looks like. So there's an artificial skin graft, and that is stitched to the tuberosity and the glenoid, and that is that's got sutures to the infraspinatus, and this is an interposition arthroplasty of superior capsular reconstruction. Or you can put a balloon into it, and this is what reverse looks like. Hang on, I've got a very nice video that, if I can make it work, I'll show it to you. Just give me a second. Okay, I think I've got it. I can make it work. Just give it a okay. So this is the superior capsular reconstruction that we did in the cadaver, and then we cut the whole skin off it, and this is what we've done, the superior capsular reconstruction. So it's not the cuff repair, but we repair the capsule, and you can see how stable it is. Okay. So now if we cut the repair, see what happens. Okay. So the superior capsular reconstruction is not a cuff repair, but it stops the shoulder from moving high. Do you understand that? Yeah. Does anybody do superior capsular reconstruction in Pakistan? No. Okay. Okay. So I'm done. Now you've got 5 minutes to ask me any questions you want to, then I can go and join my family. Yeah?
Sir, if rotator cuff is damaged, then we have to do reverse shoulder?
No, I didn't say that. So I said that if you are 65 or above, there is arthritis in the shoulder joint, okay?
Yes, sir.
And it's an irreparable cuff. Then one of the indications managing this is to do a reverse shoulder.
Irreparable. Yes, sir. Thank you.
Irreparable cuff, arthritis in the shoulder joint, and above 65. No more questions.
When we talk about the rotator cuff deficiency, mainly we mean that it's supraspinatus.
Yes and no. When we talk about rotator cuff deficiency, you can call it a single tendon injury or a massive cuff tear. So the subscap on isolation doesn't happen, but it can. And supraspinatus tears first, and when it tears supraspinatus, then you can have infraspinatus and teres minor join it. But the reason why we talk about cuff repair and repairable cuff repairs, it's supraspinatus mainly because it is more than 5 centimeters, then that means the whole cuff is gone and the outcome of that is poor. So a rotator cuff insufficiency possibly means that the supraspinatus is gone, but not necessarily because you have to define it by saying massive cuff tear or an isolated cuff tear.
Right, sir.
So remember one thing, people confuse this also. Cuff tear arthropathy does not mean cuff tear shoulder. So cuff tear arthropathy is a pathology on its own. It is called Milwaukee shoulder, and in that you have an effusion into the shoulder, you have crystals in the shoulder, and the whole thing balloons out. Every cuff tear does not end up in a cuff tear arthropathy, and the cuff tear arthropathy doesn't start as a cuff tear. Okay, so understand that difference. Because yesterday we were doing a talk on cuff tears in a sports forum, and everybody from Pakistan was saying that a cuff tear arthropathy is end-stage cuff tear, which is not true, which is not correct.
Okay. And sir, when we go for the reverse shoulder arthroplasty?
When? Yeah, so reverse arthroplasty is like I said, has to be arthritic, has to have a massive irreparable cuff tear, and has to have an age above 65.
Right, sir.
So if you can't, if it's a younger person, and there is no...
If age is 70, but no degeneration, then we should do reverse or not?
So when the age is 70 and what?
And there is no degeneration.
Of what? The cuff?
Yes, sir. Degenerative arthropathy.
So, you know, if it's less than a 5 centimeter tear and there is no arthritis in the shoulder, you can repair the cuff, depending on the quality of the tendon. Yeah, you can repair it. But if you, so age does not mean you have to put a reverse in everybody. What it means is that you're allowed to put a reverse into somebody at the age of 65 because they all have a lifespan of 10 to 12 years. The younger you put it, the high chance of having a revision. So if the patient is happy and you can do revisions and the patients would like to have a good quality of life, then you can do them early. But evidence suggests, okay, so evidence suggests that it is better to do them later. There is a big study in the Australian shoulder arthroplasty register, and they say that if you are a female, you are 65 years old or above, you have an uncemented stem and an uncemented glenoid, and you have a glenosphere of 40 or more, they survive 10 years or more in 95% of the cases. So that's where the ages come from. Yes? No?
Yes, thank you.
So what is the age that you would put a reverse shoulder in Pakistan?
So there no one do it. I think.
There is. Don't say things like that. Yeah, there is a lot of people who are doing it. I know because for sure I know because everybody talks to me and I know who's doing where. Like, okay, so when would you put in a shoulder replacement or a joint replacement of a hip and knee in Pakistan? What age?
Sir, we are not doing it. Our setup.
Well, I'm asking a simple question. I'm not asking who's doing it or not doing it. Okay, so
Usually above 65, sir.
No, that's not correct. The life expectancy of the individual in Pakistan minus 15 years is the age you can do an arthroplasty on. So what is the life expectancy of people in Pakistan? 60. Is that correct? 60, 70? Sorry?
62 years.
Yeah, 60 years, isn't it? So you can do a reverse in Pakistan, 15 years less than 60, which is 45. Because evidence say that you need to put a joint, whether it's a hip, knee, shoulder, elbow, whatever, 15 years less than the life expectancy of that particular region. So if the life expectancy of Pakistan is 60, then you can do a shoulder replacement or a knee replacement or a hip replacement at the age of 45. So 65 is European indication, not Pakistan indication.
But very less it is at 45. Mostly it is above 60, 65 year age when patient comes for replacement.
That is because we are doing what the Americans and the Europeans are doing, isn't it?
No, so patient mostly take medicine and makes a routine life up to 50, 55, 60 years.
That's a different.
After that, he becomes dependent and then he comes for replacement.
I know that's because they don't want an operation, but technically their arthritic hips and knees are there already, isn't it? So we are not treating them the way we should treat them. We are treating them what the Americans and Europeans tell us to do. So there is evidence to support that the time to put a joint replacement is 15 years less than life expectancy. So if your life expectancy is 100, then you should be putting joints not before 85. Okay, but if your life expectancy is 50, then you can be putting them in 35. It depends on what your life expectancy if your region is.
Okay. Sir, one last question. Is there any role of tendon transfer in irreparable rotator cuff tears, or is it being done?
There is a massive role. There is a massive role, and people like Colonel Saab in Lahore, you know, and then one of the other consultants in Bawalpur, they do tendon transfer. They do a lat dorsal transfer. Okay. Again, the indication for tendon transfers is very clear. You should have a functioning tendon, which can replace the function that you're transferring. The joint should not be arthritic. Okay. So if you have an irreparable cuff tear, you have a young person, you don't want to put a replacement because the joint is normal, you can do a lat dorsal transfer for these patients. The reason I don't talk about transfers is because I can't do them myself. It is a very technically demanding procedure, but a lot of surgeons in Pakistan can do them, and that's what they offer, and it's cheaper than putting a reverse shoulder into them, like this, especially if your joint is not arthritic.
Right, sir.
So the principles don't go away. If you're doing a tendon transfer anywhere in the body, you should have a normal joint. The tendon you transfer should give you function. The tendon you transfer should not lose function for you, and it should be strong enough to give you the important movement you want. So you can do a transfer anywhere in the body as long as you follow basic principles.
Right, sir.
So the correct answer in Pakistan with a massive cuff tear, which is not repairable in a young person who's not got arthritis, would be tendon transfers.
Yes, we do Episcopo procedures for these patients.
What do we do, sorry?
Episcopo procedures. That is some dorsal transfer.
Okay. Yeah, no, because I mean, my practice is totally different. I don't do tendon transfers, but I have got toys. I can do a balloon. I can do a superior capsular reconstruction. I can do a bar procedure, which is bursal acromial replacement, where I take the TFL and put it in there. Or I can do an augmentation of superior capsular reconstruction. So these are a lot of toys that I have that are not easy to do in different countries, and purely because of cost. Okay, but in Pakistan, there's a very viable option, and that's doing tendon transfers. And lat dorsal is an amazing tendon. And you know, Kamran Butt in Lahore with Colonel Khalid Saab, they detach detach the lat dorsi and then come run arthroscopically reattaches them. So, which is a skill that I don't have, and I'm dying for them to teach me. Unfortunately, they're keeping their things guarded. They don't teach me much of these things, like I said. Although I visited them a few times. Cheaper option. Cheaper option. Okay, should we call it a day?
Yes, sir. Thank you. Thank you so much, sir.
Thank you, sir.
Thank you, sir.
Okay, I'll post the video on the forum when we finish it.